This video goes with the content for the GI medications as well as a couple of eye medications. So the first part goes through the condition of glaucoma and the medications we can use for glaucoma. We briefly talked about it in response to the effect of pupil dilation on glaucoma, that medications that favor dilation of the pupil should be avoided in people with glaucoma because that can decrease the drainage of fluid. So a little more particular information about glaucoma is it's one of the reasons for blindness. So the normal function of the eye, this is the cornea, and there's fluid space between the cornea and the iris, which is the muscle, the opening of the eye with the pupil, which is kind of an open space. The lens is behind that, and we reflect the light back to the retina, and that information is sent through the optic nerve to the brain for interpretation. So all of this area needs the nutrients that all cells need, glucose, electrolyte transport, etc. Fluid is produced inside the globe of the eye called aqueous humor, and that fluid is supposed to filter through the pupil to feed the cornea and keep the iris and cornea moist. And then that fluid is supposed to drain near where the ciliary muscles are in the iris in a special drain called the canal of Schlemm. So if the person is, you can be born with sort of an anatomical problem in this area that pupil dilation can trigger an acute glaucoma, or this can start to close over time and people can develop glaucoma as they age. But either way, the eye is still producing the fluid, and if there's no way for it to drain out, then pressure increases in here, which puts pressure on the optic nerve, which can lead to blindness. So if you want to try to manage glaucoma with medication, you can use eye drops to affect this area directly, and the medications themselves will either help increase outflow of fluid, which means they'll help promote the drainage, or they will decrease production of the fluid itself. So if it drains slower, it doesn't matter, or both. So the medications that we are talking about are latanoprost, which is a prostaglandin analog, which actually helps increase the outflow, helps promote the drainage, and timolol, which is a beta blocker, which helps decrease production of the fluid. And we're talking about the medication separately, but oftentimes they're given as a combo drug with both drugs in the same medication vial. So latanoprost decreases intraocular pressure because it helps promote the drainage of that fluid. People are usually prescribed either 1 drop or 2 drops at a time. If a person's going to instill the drop, then they have to take their contacts out. They have to keep their contacts out for at least 15 minutes after the eye drops are instilled. If they're supposed to give themselves 2 drops, then they have to wait 5 minutes between drops to allow for full effect of the medication. Some of the side effects are darkening or almost like an allergic sensation in the eye. It can increase the length of lashes. You want to avoid systemic absorption, and that's why with these types of drops, after the drop is instilled, the patient should put pressure on the nasal lacrimal duct to prevent systemic absorption. Timolol is the medication that decreases production of the aqueous humor. It does, again, you can do this once or twice a day. You would have to wait in between drops if you did 2 drops, or if you were using Xalatin first, and then you'd have to wait before you could give this one. It can take a couple of weeks for it to have its true effect for the person, and is usually combined with the other medicine. Then if you look further on those slides, there's a picture that goes over the anatomy of the tear duct and the lacrimal gland, just to remind you that the patient has to put their finger there to prevent systemic absorption of those medications. There's a slide that goes over the steps for installation of eye drops, so be sure to look that over. Other conditions, so other general categories of medications that can be eye drops or used for the eyes are mydriatic drops, which are drops that promote pupil dilation. They're making the pupil dilate. And this will be given in the short term by an eye physician, an ophthalmologist, if they wanted to do a dilated eye exam to actually get a good look at the retina. So you would be sitting in the office, they would give you the drop, it would start to work, your eyes would dilate very, very big, the pupil would be huge, they can look in the back of your eye, and then you'd have to wait to drive until the medication wears off, or you'd have to wear sunglasses when you drove. The other class of medications that are used for eye procedures are called cycloplegic drugs, and what they do is they paralyze the muscles of the eye so that while a physician or surgeon is working on the eye, that it doesn't move, because you don't want them to make a mistake at all, for sure. There is a little section about ear medications. There isn't any particular ear medication that will necessarily be on the exam. They're usually, we use antibiotics a lot as drops, hydrocortisone, lidocaine as drops. There is listed on that slide what is carbamide peroxide drops, which help to soften up impacted cerumen or earwax. The other thing to look through is just to go over the rules of eardrop or ear medication installation, because that could of course be on the final exam. And then we're going to move into the GI medications. The first section of GI medications has to do with medicines that decrease acid production. And these are often used for conditions such as GERD, which is gastroesophageal reflux disease, or PUD, which is peptic ulcer disease. So gastric esophageal reflux disease occurs if this is your esophagus that would empty into your stomach, and then after you did that, your stomach will churn food around before it gets to the small intestine. If this muscle here at the base of the esophagus, at the connection between the stomach to the esophagus, is weak, then after you have a meal, when these muscles are supposed to be closed, when the stomach is mixing the food around, you could get acid up into the esophagus, which would burn the esophagus. The esophagus isn't meant for that acid that's created in the stomach. Or if you had a huge meal and there's a lot of pressure on that lower esophageal sphincter, that muscle, it could allow food to go up and burn the esophagus. Or if you eat and then lay down, gravity could allow acid to go up into the esophagus. So however it occurred for you, what people will experience is a burning pain, sometimes called heartburn, that can go into the back as well. Sometimes it's confused with cardiovascular disease, but it's essentially the sensation of burning the tissue in your esophagus. Peptic ulcer disease is an ulcer that occurs because of decreased mucus in the stomach, which can cause erosion or ulceration in the stomach, or increased acid content in the small intestine that can increase erosion in the first part of the small intestine, and you develop an ulcer. People, again, because the mucus layer of their stomach has thinned or isn't there like it's supposed to be, will have a burning pain as the stomach acid then burns and damages the tissue of the stomach. There's sometimes some subtle differences between the two. Usually when the pain occurs, people with GERD generally have pain after they've eaten or when they lay down, whereas people with peptic ulcer disease, they actually feel better right after they eat, because sometimes that coats the stomach a little bit. They might be full a little bit faster, people with peptic ulcer disease. So there can be slight differences, but the treatment in terms of medication is similar, because the symptoms are related to burning of tissue. If we decrease acid production, we can decrease the burning of tissue and decrease the symptoms. So the main classes of medications are proton pump inhibitors, or PPIs, or H2 blockers, which are histamine blockers. So the first medication that's listed on your slides is proton pump inhibitors, and our prototype is omeprazole. And what that does is it binds to the proton pump so that it doesn't work. And the proton pump is supposed to, this is your stomach cell, your stomach parietal cell, and this is inside your stomach, and then this is the blood that supplies your stomach. The proton pump is supposed to spin and exchange hydrogen for potassium. So hydrogen goes into the stomach to help make hydrochloric acid, and potassium goes into the bloodstream. So if I stop this wheel from turning, then I decrease the amount of hydrogen that can be in the stomach, and then I don't make as much hydrochloric acid, so there's less acid in the stomach. So this is usually given at breakfast or on an empty stomach before you eat. It's a capsule. You're not supposed to open it or chew it. There are some mild side effects that are listed there: headache, diarrhea, rash, dizzy. However, there is issues over the long term. So these medications were originally developed to be only used for 1 to 2 weeks to help decrease symptoms, and hopefully the area will heal itself and the person will make some lifestyle changes and their symptoms will improve. But a lot of times people will just take them forever, and a lot of times providers promoted that as well. Like, just keep taking it, it takes your symptoms away, why not? But the problem is when you change the acid content in the stomach, you will change what then comes into the intestine, and it will alter the absorption of certain vitamins and minerals, especially calcium and magnesium, which can affect the risk of osteoporosis. It also changes the bacteria content of the bowel because of a change in the content that comes from the stomach, and does put the person at increased risk for C. diff. So those are reasons not to use it for an incredibly long time. It is associated with some rare blood disorders, decreasing the production of red blood cells or white blood cells. The other option that you could use would be an H2 receptor antagonist. So here's kind of a funny thing. So these ATI, all this stuff has been up for a long time. Ranitidine was actually just taken off the market, but it is still on your exam, and is still, as far as I know, still available to use in the hospital as something for an acute ulcer bleed. But it's on the exam and it's still on ATI, so we'll still talk about it. But you can't get it now at Pick and Save or whatever. So ranitidine is a pill that you take at night before bed, or it can be given intravenously for treatment of an acute ulcer. But what it did is block the histamine receptor that's located on stomach cells. And if I block histamine, then I block the production, or a block allowing the acid production to occur. It's just a different way to do the same thing. I'm decreasing acid production. You have to be sure that their kidney and liver is working well, so they don't get toxic levels. It can cause some mild side effects: diarrhea, constipation, headache. It can cause breast development. But it did have some rare side effects, such as decreased white blood cells, decreased red blood cells. And as I said, you cannot buy it at the drugstore anymore, but it's still given for acute ulcer bleeding as an IV infusion. And it's still on your exam. The other thing you can do to decrease acids is to give an antacid. So I could give aluminum hydroxide or calcium carbonate to directly buffer the acid that's in the stomach. So we talked about calcium carbonate before as a treatment for hypocalcemia, or as well as a treatment to increase calcium to help preserve bones. That's Tums. There is some systemic absorption. If you remember from us when we talked about osteoporosis, you can only absorb 500 milligrams 3 times a day. So the more you take it doesn't mean, so I could take 2 Tums. I probably won't absorb all that calcium, but I will buffer the acid in my stomach, which would be the reason to take it that way. Aluminum hydroxide is another type of antacid. This is not a lot of absorption and less constipation than calcium carbonate, but all antacids have the possibility of causing constipation and the potential to change electrolytes or cause electrolyte disturbance, and that's the main things about them. We will briefly talk about medications that you can use for constipation or diarrhea. So the medical definition of constipation is both a consistency and frequency issue. So consistency meaning the stool is harder, drier, smaller pieces, and frequency meaning it's less than your normal, leading to symptoms of bloating or discomfort. Because not everyone goes the same time as everyone else. Some people go once a day, some people are every 3 days, some people go once a week. As long as they don't have symptoms and their stool is a nice formed stool, then they're not constipated. So if the person has smaller, drier stools or does have decreased frequency of stools where they do feel bloated and uncomfortable, then you can give treatment to try to promote bowel movements. The reason why most of the first line of treatment is to bulk up the stool itself is it's much easier to pass the stool if it is bulkier because of the way that the colon is constructed. It doesn't have muscle all the way down the tube like the small intestine where you just have that peristalsis that pushes things through in a rhythmic way. The muscles in the colon, that's why it has that appearance, what people call haustra. There's muscle bands in between each piece of colon, and it squeezes to push the next piece, the stool down to the next segment of the colon. So if there's nothing to hold on to push, if it's really tiny, it's going to get stuck. It's not going to move. So you want the bulk, you want it to be a bulkier stool to help move it through the colon. So the first treatments for constipation are always water and fiber. A person is supposed to drink 64 ounces of water a day, and every glass of or amount of caffeine they drink should be replaced with an additional glass of water. So most people don't do that. It's not very common. So certainly that is one thing that anyone can do is increase their water intake. The second thing is to increase your fiber intake naturally. Increase your ingestion of fruits and vegetables. Again, some people think that they are getting lots of fruits and vegetables in, but you have to be careful. You might not know what the fiber content of each of those things are, especially depending on how they're prepared. Once you cook a vegetable or a fruit, you lose fiber content. And once you skin them, you lose fiber content, because that's where a big portion of the fiber is. So if you ask your mommy to peel your apple, then it doesn't have the same amount of fiber in it. And one medium-sized apple, even with the skin on, is only 5 grams of fiber, and you need 35 grams of fiber a day. So when people say, oh, yeah, lots of fruits and vegetables, they would have to have like 7 to 9 servings to truly meet their fiber criteria. And not a lot of people can say that. So there's always room for improvement. If they just can't get that much fiber in by normal dietary intake, then the first step is an insoluble fiber supplement to help bulk up the stool to make it easier for the colon to push the stool through. And that is psyllium, which is Metamucil. You need to take it with a full glass of water. Each cup is another 5 to 6 grams of fiber. So you have to look at the back. Sometimes people are like, oh, I don't like those drinks, they're so chalky. I'll try that FiberCon with those tablets. Each tablet doesn't even have a gram of fiber in it. It's like 875 milligrams. So you'd have to eat a lot of those tablets in order to get the amount of fiber that you want. So it's really not worth it financially, I would think. So you're drinking your water, you're increasing fruits and vegetables, you've actually added a Metamucil fiber supplement, you're still constipated. The next step is a stool softener. So Colace is a medication that does not act on the colon at all. It's only supposed to land kind of on that hard stool that's stuck there and melt and therefore increase the water and fat content of that stool, soften that stool, and hopefully make it easier to pass. If that doesn't work, the next step is an osmotic or saline laxative. This doesn't increase muscle contraction per se, it just pulls more water into the colon so that hopefully the stool gets a little softer if it's very dry to help it pass through. And our prototype for that is polyethylene glycol, which is Miralax, which is a powder that doesn't have much of a taste that you put into any kind of drink. If that doesn't work, then the next step is to take a medication that will promote muscle contraction, a true laxative. And that is something you should reserve for the very last step, because once a person gets used to those, it's hard to stop using them. They need them then in order to have a bowel movement, so people can become dependent on them. The one that's listed there is bisacodyl. There's going to be much more cramping because it's causing contraction of the muscle. So a stimulant laxative is the last resort. Treatment for diarrhea is aimed at slowing the bowels to increase water absorption so that stool is less watery and it will decrease the frequency. So you would never want to give an anti-diarrheal medicine to a person that has an infectious diarrhea, because then you're keeping the infection inside. Just like you would never want to give a person a cough suppressant who has an infectious pneumonia, because then you're keeping the bacteria inside. So if a person has diarrhea, again, it is frequency, increased frequency from normal, and change in consistency where it's softer or watery. So opioids, over-the-counter Imodium has weak opioid activity, or the prescription strength Lamodal is operating on the mu receptors on the bowel to slow them down to allow for more water absorption and decrease motility, so that'll take care of diarrhea. Other things that are listed there, if your diarrhea is related to bacteria imbalance, then you could use probiotics. There are other types of diarrhea conditions that are related to other medical conditions, but the main thing is that you want to slow transit and to allow time for increased water absorption. That's the principle of Imodium. The next medication is a medication frequently used for people with pancreatitis or have a decreased function in their pancreas. So when someone eats something, the food goes through their esophagus into their stomach, where it's mixed around and then ends up in the first part of the small intestine. And a lot of activity occurs in the first part of the small intestine, because that's where the liver and gallbladder deposit bile for emulsification of fats. And the pancreas deposits the enzymes that are necessary for digestion of sugar, fats, and proteins. The pancreas releases amylase, lipase, and proteases in order to aid in digestion. So it's a very, very important job that it has. If a person has frequent pancreatitis, they're scarred, or a pancreas that doesn't function as well, or part of their pancreas was removed because they had surgery, then they are missing some of those key enzymes that are needed for absorption. So you can replace that with a medication called pancreolipase. This is a capsule, and the medication is inside, and the patient would take this 1 to 2 hours before they eat, so that it ends up in the small intestine. They're waiting when their food gets there. So they kind of have to know their schedule. There should not be any systemic absorption. It just opens up, that capsule opens up here so that the enzymes are available for digestion. Issues would be nausea, vomiting, diarrhea, which could occur without the enzymes as well. Usually it definitely helps the GI function of a patient with chronic pancreatitis. There is the next slides talking about malnutrition, reasons why people would be malnourished. If you need to supplement nutrition for somebody there are ways you can do that. So obviously, you're hoping that they eat a healthy diet. If for some reason they aren't able to eat as much as they need to support the body's needs, then you can replace that for them in several ways. Say they had surgery, they can't swallow, there's a problem with the liver or pancreas, and so we need the food to be deposited lower in the GI tract, but the GI tract still works. Then you can still use the GI tract, and that's called enteral nutrition. You want to be able to use the GI tract if you can. It's always best if you could. It's best if the person can eat. If they're not getting enough calories, then it would be best to give them oral supplements. If they can't do that, then you could put a G tube in or a J tube to try to give them nutrition that way. That way they're still using their bowel for absorption. And you can pick different types of tube feeding based on the nutrition needs of the patient. If the GI tract isn't functioning at all, maybe there's a huge obstruction, maybe they have some kind of leak that's taking a while to take care of, maybe there's no way that they're so malnourished that there's no way that they can catch up without some kind of extra something. And that it would be a reason to use total parenteral nutrition, which is IV nutrition. So it's a bag, looks yellow, it's a big bag that has proteins, fats, carbohydrates, all kinds of electrolytes, vitamins, and minerals. And it has to be given through a central line because the medication itself, because of its sugar content especially, can promote infection in the area. So it must be given through a central line. And the person's fluid status and blood sugars need to be monitored closely anytime that they're on TPN. That's the major thing. That the patient is getting it administered in the safest line, which would be a central line, like a PICC line. That they have strict INO, so we're being sure that what we put in their veins does filter through and get out. And that because the sugar content can be high directly into the bloodstream, they might need insulin temporarily, so we have to really watch their blood sugars. The last medication that's there is for obesity. So there's a lot of different medications for obesity. Some of them are appetite suppressants. Some of the medications are meant to change how you absorb fats. So the one that we have on our list is orlistat, which is a lipase inhibitor, which means the person can eat something fatty, but because the lipase, or the enzyme released from the pancreas that helps with digestion of fat, is inhibited, then the fat can't be absorbed, and instead will just whoosh, slide out the old GI tract instead of being absorbed into you. So if you decide, you know what, I am going to change my diet, and so today for lunch I'm going to have a salad and some lean chicken, then it's not worth taking the orlistat with that meal because it doesn't have a lot of fat in it, and so it won't matter if you take it or not. But if you're like, you know what, I'm trying to lose weight, but I'm going to this pizza party, I'm just going to take this medication so less of the fat is absorbed, then yes, it will help you absorb less fat, but the fat has to go someplace, and it's going to whoosh out the GI tract, and that's the problem, is people will have oily, frequent stools, and you can have some, as it says, flatus with discharge. So that's sometimes a reason why people don't stay on these medications for very long.